Happy fall. Okay. The first day of fall. Okay, so this was the last case we did. So why don't we start on this case? Jonah, why don't you take this one?
Sure. So we've got a 15-year-old with a shoulder injury during a tackle in rugby. We've got a fluid-sensitive axial sequence through this shoulder. Now, I'm seeing some irregular edema kind of posteriorly, kind of tracking back along that way, as you're pointing out, a little bit extending to the humeral head too. Okay, yeah, it does seem to be real. Okay, now I'm seeing sort of hypo-intense structure with thickening and signal abnormality. Yep, right there, which is coming back and attaching to the glenoid. It seems to extend from the glenoid to the humerus, and it looks like it's torn.
Yeah.
Okay. And the question is how far down we are. It looks like we're pretty low, so I think this is an injury to the inferior glenohumeral ligament with tear.
Here are the coronal images. So this is an avulsion of the posterior band of the inferior glenohumeral ligament from the humerus. Hi, Jeff.
Hi.
So, oops, let's go back here. And you can see that it's avulsed off right in those location. So this is part of this is inferior, and it's coming back toward the capsule, notice, as opposed to so this isn't rotator cuff. This is really more the capsule, and remember the inferior glenohumeral ligament is really a thickening of the capsule. This is an avulsion of the capsule off here, deep to the teres minor tendon here, and it's pulled in. So this is an avulsive tear of the inferior of the posterior band of the inferior glenohumeral ligament. It's also called the reverse Hegel lesion, humeral avulsion of the glenohumeral ligament. Reverse meaning it's posterior. Well, reverse means it's really kind of coming off the humerus and it's posterior. Okay, Jeff, what do you think of this case?
So we have axial, let's see, T1, T2, and right now, so I see some increased signal. It's superficial to the, let's say, subscapularis tendon. Actually deep, superficial and deep to it. It's essentially looks like some synovitis in that region. I'm seeing what I believe is at this level, I think is the anterior band of the inferior glenohumeral ligament, just superficial to the anterior inferior labrum or anterior labrum.
So this could be anterior band of inferior glenohumeral ligament or middle glenohumeral ligament. We'd have to follow it up and down to see where it goes, to see what that is. So that's the area we're concerned about. Here's another cut.
So it looks like on the image on the left, there's some intermediate signal within this structure, suggesting there's some degeneration.
Yeah.
And on the right, it looks like it's kind of fragmented.
Yeah, so that's fragmented. What about this structure back here?
So it looks like it has signal intensity of the marrow.
Right.
So I think it's spurring.
This the other couple of days. So this is really ossification of the anterior labrum, and here we need to follow it up and down. I'd really be concerned about either an acute strain or injury to the middle glenohumeral ligament or chronic tendinosis, and this could either be middle glenohumeral ligament more likely, or less likely the anterior band of the inferior glenohumeral ligament. We'd need to follow it down and see. Maybe the two are separating here, but you would really need to follow it all the way down to see where they go. And there we can see the two little structures there. And if we continue farther down, what are we seeing here?
It's continuing further down, seeing the calcification of the anterior inferior labrum, and then the structure is kind of we still see it separate from the, I think it's looking more like, again, it could be the anterior. Actually, okay, I think we're seeing two separate structures now. I think this is the middle glenohumeral ligament you're pointing to there, and then just behind it is
probably the middle glenohumeral ligament going there.
Yeah.
This other structure that we saw the two separate now becomes this structure here.
Yeah, anterior band.
Well,
Maybe.
So, but this is actually the labrum here. Superior, the labrum was really ossified. Down here, the base of the labrum is ossified. But now, that if we do the next cut down, you can see that this is clearly labrum. So what we're actually seeing is an ossified labrum, a labral tear more superiorly, and some degenerative disease of the middle glenohumeral ligament. This is really more to point out, to really figure out what these structures are. You know that the middle glenohumeral ligament fuses in with the deep subscapularis muscle and tendon. You know that the anterior band of the inferior glenohumeral ligament goes down and becomes a fold in the capsule and doesn't go to either the subscapularis or the glenoid. And the labrum comes down and ends up attaching to the glenoid unless the tear extends into the inferior labrum. In this particular case, we saw those two structures. One was the middle glenohumeral ligament. The other one came down and attached to the labrum, and therefore we had a tendinosis of the middle glenohumeral ligament and a tear of the anterior labrum, as well as ossification of the labrum. So it just shows how by following these structures you can differentiate what the structures are. And those are really the three structures to think about there. And here we can see acute marrow edema from an acute Hill-Sachs lesion. We've seen plenty of these. We don't need to, oops, sorry about that. Okay. So here we can see edema, very typical of the posterior superior aspect of the humeral head where we see Hill-Sachs lesion. And here we can again see the same thing. We follow this further down. So we know this patient has had an acute anterior dislocation. So obviously the next thing you have to look at is the anterior labrum. And here, if we come down here, we can see that there is abnormality here. There's some edema within the anterior inferior glenoid, but we know that typically when you have the anterior dislocations, you will commonly get traumatic injury to the bone here. You may get a fracture, or you may just get trabecular bone injury. In this particular case, we also said the other thing you could do is shear off the labrum, and this is a nice labral tear. Now, typically when you shear off the labrum, you'll tear the labrum and you'll tear its periosteal attachment. But you can't just tear the labrum and the periosteal attachment can stay intact, in which case this is called a Perthes lesions. Now, and this is kind of more fine point for the interpreting radiologist. The orthopedic surgeon doesn't really care. When they go in there and repair it, they'll just complete the tear and put it in their suture anchors and do a repair. So the actual presence of the periosteal attachment at least most of the surgeons I know of doesn't really matter much, but I still describe it, and this is considered a Perthes lesion. John, what do you think of this?
In Campbell's, Perthes really is not used as such to describe the lesion. But in terms of history, Perthes came out with a paper in 1887 or something like that. And then after that, Bankart in 1909 actually described injuries to the labrum. So Perthes is kind of a little confusing. You're better off using Bankart and then describe it.
Good. Okay. Okay, so here is just kind of an evolution. Show you what happens over time. Shirley, what do you think of this case? This patient had an acute dislocation a week before this MR.
All right, so we have axial T1 and PD fat sat images. No, these are sagittal. These are coronals. They're axials. Okay. So the anterior labrum is torn, and there's some irregularity of the. Well, I don't see any abnormal bone marrow signal intensity of the glenoid itself. And regarding the periosteum, there's a little bit of a fluid signal gap between the labrum and the glenoid, but I don't really see distinct periosteal stripping.
Yeah, and here's the normal, nice thin periosteal attachment. So this is a anterior labral tear, transverse tear, where the periosteal attachment is intact, which, and again, you can describe the periosteal attachment if you want. Again, to the surgeons I know, it doesn't matter. But I usually, when I see it, I usually describe it. And most musculoskeletal radiologists would want to call this a Perthes lesion, but as John was saying, that's really not an important distinction to make. But notice how thin the periosteal attachment is here. So this is on 4504. Now we're going to scan the patient about 5 weeks later. And what do you see here?
So now the patient's undergone an arthrogram, and these are axial T1 fat saturated images.
Yep.
And now there's thickening of the periosteum. You still see the labral tear, but the periosteum looks thick.
Yeah. So this just lets you know what the body does to try to heal itself. And we all have seen thickened tendons and ligaments, and we call them compatible with prior injury. This happens quite rapidly as the body tries to heal it. And notice how much better you can see the details of the tear right after the injury, and how this all get obscures when you start getting scarring in this particular area. So this is, you can see that the thickening of the soft tissue structures can occur in a matter of weeks, not really months or years. So this is the evolution of a Perthes over 5 weeks. Okay, and you can also see this on an ABRA view. Here's an anterior labral tear here. We can see the periosteal attachment is still intact. This is on the regular view. When you go to the ABRA view, you can see the separation of the labral tear and the thickened periosteal attachment.
Is this really an ABR or a hyperflexion and external rotation?
Well, I don't think it's flexed because it's up over the shoulder, John.
Well, you can flex the arm forward and go straight up to 90 degrees, and then externally rotate the arm. So you do not have to abduct the arm. Abduction of the arm is quite different. It's away from the body. And I don't think anybody, especially with a sore shoulder, can abduct the arm. I've been thinking about this, and I think it's a misnomer.
Okay, all right. I'm trying to think when we actually, basically it's above the arm. I think you end up basically in pretty similar position, because when they lie on their back, the elbow falls back to the same plane as the torso. So you end up with the same position as if you completely abducted the shoulder, even though to get it in that position, sometimes it's easier to bring the elbow forward, flex the shoulder, but then you have to externally rotate it to have it lie down on the table. So
I can externally rotate my arm, but not that well. But then
okay.
Everybody try in a room, see if you can do it. Go straight away from your body with your arm and see if you can abduct it and then externally rotate it.
All right. Well, it's called an ABRA view, even though
I understand, John, but if it was me, I would call it hyperflexion view with external rotation.
Okay.
Because nobody with a sore shoulder can do this, I can assure you.
Fair enough.
By abducting. I mean, so the motion as represented is straight abduction, and they just cannot do that. Yeah. Anyway, I'm sorry to interrupt your.
I think historically, when they were first trying this out, they probably had young volunteers who could abduct. And in reality, with patients, you may be right. But you get to a similar position eventually, whether you do it through a flexion or an abduction.
What I'm seeing is sore shoulders.
And this probably was initially not done on sore shoulders. The sore shoulders probably came later, but it got named after the volunteers.
I got it. I know who you're talking about. So, Mr. Tierman, yeah, Dr. Tierman, yeah.
Right there at the bottom.
So this is a 17-year-old with history of multiple dislocations. This is a arthrogram, I presume. There's contrast there. We are looking at the anterior labrum looks thickened, and there's I think so. Okay, there's blunting of the posterior labrum for sure. Yeah, maybe that's why the anterior looks thickened, because the posterior is gone. And then A-bear view shows. Well, actually, the A-bear view shows a little bit of fluid getting between the anterior labrum and the glenoid, so that looks like a tear.
So you can see, so in my experience, doing the A-bear view hasn't markedly increased the sensitivity, but you've seen 3 or 4 examples in the lectures where it does increase the sensitivity. We will typically do ABER in the young athletes, but not in the non-athletic population. Okay, let's see. Jonah, what do you think of this?
Sure. So, well, what is the lesion? We've got an axial view of a shoulder, which appears to be performed as an arthrogram. Now, we've got this kind of oval, loculated, intermediate, low-intensity structure kind of coming around the anterior labrum, kind of like that, yeah, as you're outlining there. Now, as this seems to be an arthrogram, there doesn't seem to be contrast extending into this lesion. Okay, so now we've got a fluid-sensitive sequence, and it's of fluid signal. So I guess this could be a labral cyst. It doesn't seem to be communicating with at least the arthrogram. Okay. Okay.
Yeah. So this was a non-communicating paralabral cyst. There was an anterior labral tear here. You know, fluid gets through these. It then becomes very inspissated, so it's really kind of thick gelatinous structure over time as the fluid actually gets resorbed. And but there's still enough fluid, still enough water in it to be bright on the PD FATSAT images. But once this becomes thickened and inspissated, the connection to it really becomes often blocked off. So when you put contrast in it, you don't necessarily fill these. And if you do a delayed image after you give intra-articular contrast, sometimes you'll start seeing a little bit of the contrast percolate into these right near where the connection is. But it can be a very poor communication, so it's not uncommon for the paralabral cysts not to fill with contrast. Yes?
How long does it typically take all of the contrast to resorb?
To resorb?
Yeah.
Well, typically, 24 hours later, you will not see bright signal intensity on a T1 weighted image. If you put in undiluted contrast, which occasionally people have made the mistake of doing, and then you get MR images, I think I showed this in the knee, it's all black on all the pulse sequences. And then if you call the patient and get them back in about 4 hours, the contrast will be about the right concentration. So in about 4 hours, you go from 0 dilution or 1-to-1 dilution down to about a 1 in 200 dilution. So, and then it's kind of exponential. So then it kind of tails off, but usually 24 hours later, you won't see contrast in it. But people have shown that the putting contrast, either iodinated contrast or gadolinium into the joint space, will change the coefficient of friction for the articular cartilages for up to 4 to 6 weeks. And therefore, some people recommend not doing this in the middle of a season for an athlete, or telling the athlete not to get back into really active sports for a couple of weeks to allow the coefficient of friction to get back to normal, because you dilute the normal viscous lubrication within the joint when you put in the contrast. And not everybody recognizes that, but I think it's important. So I particularly do not like to do arthrography in the middle of a season if you think the individual is going to go back into playing right after it. Okay, Jeff, what do you think of this case?
Okay, so we have, looks like a coronal and, okay, so we have a T1, coronal and axial images on the left, no gadolinium, and then on the right, looks like P fat-sat, coronal and axial images are after intra-articular injection of gadolinium, and
I think these are
so we see
fat sats over here, no gadolinium, and this is an arthrogram with T1 fat sats. Go ahead.
Okay, so in the bottom right corner, there's an arrow pointing to salient finding, and it appears on this image, I think we're just a little bit superior. We're just at the level of low subtube velocity. I think so. We're seeing a structure there. I mean, I would say we're a little too high to confidently. Okay, so you're basically trying to tell me that this structure I'm seeing coronal image is the same as this structure here. I think this is. I think there's a high attachment of the inferior glenohumeral ligament.
This is an area where the superior glenohumeral ligament, the middle glenohumeral ligament, and if you have a very high attachment of the anterior band of the inferior glenohumeral ligament, they can all come into this particular location. So you really need to look and follow the abnormality down. In this case, it looks like this contrast structure is extending along a longitudinal structure, and this was actually a superior tear of the labrum in this location, where it comes out.
How do you distinct that from the sublabral frame? And it looks like so anterior and up, so it must be.
But because on the images you can see that the contrast is actually going into the structure of the labrum itself,
and you don't see that with the sublabral
and you don't see that with the sublabral frame. Okay.
So 20-year-old rule out labral tear. These are two axial images in a patient who's had an arthrogram, so axial T1 and PD fat-sat. And the anterior aspect of the glenoid has some little bright signal intensity on the T1 and low signal intensity on the PD fat-sat. But I don't see...
Where is that?
Just above where your arrow is?
Right here?
Yeah. And then, all right, so then our arrow is pointing to a focal layer of contrast going over what looks like the anterior labrum, but...
This is probably the superior insertion of the anterior band of the inferior ligament there. This should be the labrum here. Oops.
Okay, and then there's an arrow pointing at a Hill-Sachs lesion.
So, I'm sorry, what this was a tear of the tip of the anterior labrum, and the tear of the labrum was actually displaced laterally. So this, if we went up and down again on these images, this turned out to be a displaced labral tear. Sorry. On this one cut, I was thinking that this was going to be, I forgot this particular case. You can also see that there's some blunting of the posterior labrum. Okay.
A little correction on my side.
What, John?
Perthes described the lesion in 1906, and that was the detachment of the labrum from the glenoid, and described an operation for it. Now, Bankart, 1938, described detachment of the labrum, tear of the labrum, and also avulsion of the periosteum.
Okay. Thank you.
So a periosteum avulsion was not described by Perthes. And in orthopedic literature, Perthes gets very little credit for shoulder problems.
So in radiology, then, a Perthes lesion is a tear of the labrum but an intact periosteal attachment, and a Bankart tear is a tear of the labrum with a tear of the periosteal attachment.
That is correct.
And I don't really think it's an important distinction, but
well, it's not. But that's why that's why Perthes is not even in the index.
yeah, thanks.
So here we have, I presume that's contrast. There's also arthrogram, axial images of the shoulder, and we have. I don't know if you're in the middle of the labrum, because I'm not seeing the normal anterior posterior labrum. They look blunted, and there's some densities or attenuation within the joint space that is continuous with the anterior labrum on this side. Yeah.
These are actually streaky portions of the anterior and the inferior.
Oh, okay. All right. And so there's some thickening there along the anterior periosteum of the glenoid.
So what this is called an Alpsal lesion. This is actually a tear of the anterior labrum. The periosteal attachment stays intact, so that's a Perthes lesion. But then it displaces anteriorly and then becomes fibrotic, fibroses down, scars down to the anterior aspect of the glenoid, and this is called an anterior periosteal sleeve avulsion. This is important because if you want to repair this, the surgeon has to know that they have to go in and free up this scarred in portion of the anterior labrum, put it back in the normal position, and then fix the anterior labral tear.
Well, but I'm confused there. I thought that the previous one, the one you call Perthes, was anterior periosteal sleeve avulsion, because it is a sleeve avulsion, right? It's taking off the, ripping off the periosteum.
Yeah, well, this is one that's ripped off, and then you have scarring in here, in this location.
But the thing is that
a Perthes does not have the scarring, and it's not scarred down to the bone.
Right, but that one doesn't describe.
But this, John, this is old injury with glenoid with the labrum tacked down and healed in that position, with probably multiple recurrent dislocations.
Correct. Yeah.
Capsule posteriorly, I think that's the inferior part of the inferior glenohumeral ligament.
Right.
How lax it is. So this shoulder is pretty lax all over, I think.
Right. So this.
There is really no labrum posterior if you look at it. It's kind of
pretty blunt back here. Right. But I'm pointing this out because whereas the Perthes lesion is not really an important thing surgically because it doesn't change what they do surgically, having the labrum displaced and scarred down to the bone does change things because you have to describe it so the surgeon knows when they go in there, in order to repair it, they're going to have to free up the scarred labrum, put it back in the normal location, and then do their surgery. So
yeah, there's a lot of scar tissue there, so it's very helpful to the surgeon to describe it. You have scar tissue all over the place there, don't you?
Yeah, this is probably the inferior glenohumeral ligament. Again, we're only seeing one cut. We'd have to characterize it by looking at all the images through the area.
But that's still a tissue of scar tissue. There's got to be something. It's not fluid.
Yeah, well, it's not a normal shoulder. You're right. Yep. Okay. And here's another Alpsal lesion where we can see thickening of the periosteal attachment, displacement of the labrum, which is again scarred down to the bone here. So this is another Alpsa type lesion.
I'm still confused. So is it the fact that the fractured labrum goes there that causes fibrosis, or whether if there's just fibrosis, that's enough to call anterior periosteal sleeve?
It's the display, and I personally don't use the Alpsa. I just state that there is a tear of the anterior labrum, which is anteriorly displaced along the anterior margin of the glenoid, and with scar tissue. The problem with a lot of these words, and a lot of people really like them, but a lot of the words that are commonly seen in the radiology literature aren't really used that much in the orthopedic literature. So sometimes, and vice versa. So often I think it's better to describe the findings rather than put some sort of a alphabet soup of words on it. If you work with a surgeon a lot and you use the same terminology, then it's great to communicate the most efficient way possible. But a lot of these terms, as we're finding out now with John, the Perthes lesion may get very confused because there are a lot of other Perthes lesions in the body. And so you need to know the orthopedic surgeons. And if you don't, it's better to describe the findings rather than use one of these terms for it. Let's see, Jonah, what do you think of this case?
Alrighty, so we've got a young adult, and we're ruling out a labral tear, a couple axial images, and well, I think we do have our labral tear anteriorly, potentially another sleeve avulsion. I'm free to go with the few that we had before.
So here what you can see is an anterior displacement of the torn labrum, just like before. Here we can actually see the capsular attachment in this particular case, but this is all scar tissue where it's scarred. So we have another displaced, scarred-in tear. Here we can see that the patient had a subacute Hill-Sachs impaction injury. This patient had recurrent dislocations. As you can expect, this is on 4/21/07. Now what do you see?
Okay, well, now we see kind of a lot less of that inflammatory.
Okay, so we're 11 months later. This patient has not had surgery. And now what?
Yes.
Go ahead.
Sorry. Yeah, so it seems like things have actually kind of reattached or scarred down, but it's sort of anterior and kind of around on the other side there where it.
So here is actually the anterior labrum. And this is scarred down here. We have a blunt anterior labrum there. The patient is still unstable. And this patient, after this MR scan, went for surgery. They freed up the displaced, scarred-in labrum, replaced it here, and then fixed it in this location. So when you see this kind of thickening anteriorly here, that's kind of an ant mini that you're dealing with an anteriorly displaced tear or an Alpsal type lesion, which if they need to do surgery, they need to free it up and put it in the right location and fix it. So this is right after the acute. This is the acute injury, and this is 11 months later.
Did they know if they tightened the capsule?
I don't know if they tighten the capsule or not, John. I don't think I have the post-op images.
Okay, because that probably wouldn't work. It would still be loosened.
Yeah.
I mean the Bankart. If they did a Bankart,
yeah,
those usually probably need bony procedure, I would think.
Yeah. So, but on this one, I know that they put it anterior and they put it in suture anchors. Whether they did anything with the capsule or not, I'm not sure.
Yeah, I'd be leery of just doing that. But Bankarts fail, so it's not.
Yeah. Yeah.
I'm not frequently.
Yeah. So, Jeff, what do you think of this?
So a coronal PD fat set image, and I see post-surgical changes in the glenoid from labral repair, possibly anterior labral repair, and it looks like there's also synovitis in the axillary pouch, and we're seeing the arrow pointing to a structure there, which I believe is the it's going to be part of the inferior glenohumeral ligament complex, and I think it's going to be part of the axillary pouch.
Okay, so
so now we're seeing axial images here, and it looks like so now what we're seeing is again post-surgical changes, and it appears though that there may be a recurrence of a tear of the anterior inferior labrum, it looks like it's attached. It looks like that what we have is essentially it's displaced anteriorly with attached periosteum.
Okay.
So it looks like I mean, it doesn't look to be scarred in per se, but but this is definitely a variant of a Perthes lesion at least.
Well,
Yeah.
so what we have here we can see the post-op changes here. We can see the anterior labrum is now torn again, and as you said, displaced anteriorly. And here we can see the capsule comes across there and is containing the fluid. So that's a re-tear. And if we go back here, this is actually the anteriorly torn and displaced labrum on the coronal plane that we can see better on the abdomen.
Okay. The surgery, the anchor is in the wrong place, it seems, and they missed a boat in repairing this. It seems they're too far superior, and this is more of an inferior kind of a lesion. So the anchors are, well, I don't know what they repaired, but they didn't repair the problem.
Okay. Okay. Shall I?
Yeah, axial T1 and PD fat set images in a patient who's had an arthrogram. And the anterior labrum looks blunted, and maybe there's some cartilage defect as well, anterior glenoid. And there's some low signal intensity loose body anterior to the glenoid.
Yes, sometimes you just get stranding in these patients. You would have to look up and down to see whether it communicates with the synovium or not. So it looks like there may be some anterior displacement of the labrum, and here we can see that the disruption of articular cartilage, and these glad lesions, glenoid labral articular disruption. Again, I don't like using that term. I find the term confusing. I just talk about the articular cartilage injury. And here it's undermining, and you've got a flap tear.
That's an articular fracture with a loose body. The way I would think it would.
You think it's a bony fracture or just a cartilage fracture?
A cartilage fracture.
Okay.
But there is a little bone to it. I think some bone went with it, a sliver of bone.
I don't know. And
I can't say, John. You're the radiologist.
Okay.
I'm just.
Here are the axial images, again, where we can see the full thickness defect, in this case on a little different plane of the articular cartilage, another articular cartilage lesion associated with a tear. Remember, you should not have contrast going beneath the labrum below the equator. And so this is an anterior inferior labral tear. The periosteal attachment is still there. And I do believe there's some bone injury here, as well as a fracture going through the articular cartilage. So another so-called glad lesion. Another patient. See, who did the last one? You? Yep.
All right, so axial T1 stir sequences, coronal and axial stir. We have kind of mixed signal within the anterior labrum. Actually, inferiorly, we see, well, there's some subchondral.
So this is 3505.
Okay.
This is right after an anterior dislocation.
Okay.
And we can see there's some abnormal signal within the anterior labrum,
as well as
maybe extending the inferior labrum,
yeah.
thickening of the inferior capsule.
Yeah.
This is on 3505.
Mm-hmm.
Then the patient came back 2.5 months later, and this is what it looked like.
So it looks like now we have this thickening and irregularity of the anterior labrum with maybe some fluid on the stir images that's going between the glenoid and the labrum right there. Yep. And then we have this reactive edema and probably arthritic changes secondary to the injury to the labrum.
So if we go back here I really can't, in in retrospect, see the articular cartilage injury. So there's certainly been some injury to the labrum here. Maybe if we had an arthrogram, we could see it better. But what's happened over time is we now have the development of a degenerative subchondrocystic formation within the glenoid, and now we can actually see that there's a tear really at the base of the labrum. So sometimes these lesions are more obvious when the body has a reactive change to the injury.
I have a question on the original case, just one slide back. So if you see this and I'm presuming it's a young patient.
Yes.
And you see this intermediate signal intensity of the anterior labrum, do you just say that suspicious for tear, and that's all you say? Because if it was an older patient, say they were 60 and you saw this, would you say degenerative tear?
Well, I know this patient had an anterior dislocation. That was in the history. I can see that there's marked thickening of the inferior capsule here, and really I don't see a good inferior labrum here. So in this particular case, I would call this an anterior-inferior labral tear. Now, as far as the articular cartilage, maybe in retrospect it's a little bit inhomogeneous here, but I probably wouldn't call a labral injury in this particular case at this time, but I would a couple of months later.
There are stages of healing, like any part of the body. There's stages of healing in the shoulder, like every other joint. This is a late stage of healing. Maybe it's subacute or more chronic.
Yeah.
And so you have scar tissue, and eventually the scar tissue contracts and becomes permanent and doesn't contract after a year. So it takes a year for the healing to take place completely. So I don't know where this is in terms of healing. Although you have 5/16/05, I don't know what the next date is.
Yeah, and we didn't follow any further. This is also an arthrogram.
Yeah. So anyway, this looks like there was a fracture of the glenoid.
Yeah, I'm not sure if it's an actual fracture or whether this is beginning degenerative subchondrocystic changes. Loss of the articular cartilage.
Right. It's sure suspicious, but anyway.
Yep.
You're the boss, John. You got the big bucks.
Oh, you're right. Okay. Jonah, what do you think of this case?
Alrighty, so it looks like we've got another arthrogram. There's an axial image, and after that anterior labrum, we're seeing this kind of linear signal abnormality kind of working its way through. Yep. So I'm not seeing any involvement of the underlying osseous structure focused on this cut. Yep.
So it looks like we have signal going here. This is contrast going through a tear in the articular cartilage, undermining the articular cartilage and going into the anterior labrum. Also, if you notice here, we have a poorly developed posterior glenoid here with some retroversion of the glenoid face. Okay, and here's the coronal image. What do you think of that?
Also deformity of the head.
Yes, some
okay.
Deformity too. Okay. Yeah, so there we see that cartilage defect again, and we see our contrast getting in and dissecting it out. So and yeah, there it is again. This is another glad lesion.
Okay, Jeff, this was a Major League Baseball pitcher with pain and weakness.
So we have the axial, looks like PD and PD facet images. Looks like an arthrogram that was done, and on the what I'm seeing is let's see, there's fat there. So it appears that we have an anterior inferior labral tear, and
so where would you? So
I'm wondering. No, I think it's an osseous. I think it's a bone. Well, it could be bony Bankart. I see a signal there that's marrow signal. It could again be a calcified or ossified anterior inferior labrum versus the bony Bankart lesion.
So you need to follow it up and down, and here's what it looks like in this.
Yeah. This definitely, no, this is, I think this is an ossification of the labrum. I mean, it doesn't, what I most, yeah, labral obstacle, okay, great.
Yeah, so this is a big labral ossicle from chronic repetitive trauma. And, you know, we see this in a lot of areas. This is really pretty unusual. But that's what this was. Yes.
That posterior glenoid looks abnormal too. Is that congenital in this case, or was that because of pitching?
My guess is that this was probably congenital, but Major League Baseball pitchers often will have also injuries to the posterior glenoid, and that's due to weightlifting, because the two muscles whose strength correlates with the speed of the fastball. Anybody know what those two are? One is the pectoralis major. Anyone want to guess what the other one is? The other one is the latissimus dorsi. So those are the two muscles that pitchers really work on to try to improve their fastball. So bench pressing is important in the training for pitchers, and in doing that, you if they don't do it properly and they allow their shoulders to go too far down in the process, and they like to lift more weight, they kind of like to bounce their shoulders off the posterior labrum, in which case it's common to get posterior labral tears. I think we'll see some more of these in Major League Baseball pitchers, but that's a common injury. So this could potentially be an acquired lesion, though this shape really looks more like a congenital type, a mild congenital anomaly.
That dark signal that goes across the entire glenoid, is that
John? John?
Just one. Yeah, go ahead, John.
Pitchers are congenital.
I'm sorry, I didn't catch that. What?
Pitchers are congenital.
Pitchers are congenital. And
we normal people couldn't do what they do.
And it's what John's referring to is that pitchers get both. Pitchers who are really successful have to get in that abducted, externally rotated position like we talked about before to get that extra amount of arc in order to put more momentum on the ball. And therefore, people who are likely to be good pitchers probably have some degree of instability in order to allow them to get into that position. And so this may actually help them get into that position. We also know that between 13 and 15 in pitchers, they actually developed a bony changes on the pitching side that they don't have on the non-pitching side, which also helps them get into that position. And therefore, it's rare to find someone who's actually a good pitcher who doesn't start at around 10 years of age, because it requires that bony remodeling that only occurs in the early teens in order to be able to be a good pitcher. So John may be right. This may be a little bit of a congenital anomaly, which may actually help this person become a pitcher.
Like I said, there's stiffers and loosers.
Right.
yeah, so looking at that, see the signal across the glenoid, is that labrum or is that thickened? Yeah, is that the whole thing across? No, going, yeah.
Right here?
Basically going all the way across the glenoid, that dark signal going all, yes. So is that just where we are scanning
that's
it?
Labrum.
So this is the inferior?
Sorry, that's articular cartilage. This is articular
so that
cartilage.
would be thickened, right? That's a thickened cartilage that we're looking at.
No, it's normal cartilage. And then here we can see this would be partial volume of the curving labrum here, and then this is the labrum and the ossicle anteriorly there. Okay. You did the.
Yeah, I did.
Okay. Jonah, what do you think of this one?
Okay, so we've got a 41-year-old female who's got pain and aching for 5 months. And let's see, so we've got an axial image here, and now we're seeing this sort of, yeah, so we're scanning through now, that's more helpful. Okay, so then, yeah, anterior to the labrum, there's this kind of triangular shaped hypointense
Okay, so this thing right here.
structure of this guy. Now, this is looking like it could be a mimicker of a labral tear. Let's see. Oh, pointing to some cystic change back there.
Okay, so there we have inferiorly. There is right through the mid portion of the labrum, and we have this abnormality. A little bit of irregularity there that looks more like traction injury. And then superiorly, let's see if we go to the oblique sagittal images. So,
Okay.
go
It's
back.
like somebody thought it was
So,
a tear.
this was
Still
called
thinking
an anterior labral tear. Okay, this is on 8/23/13. So now this is 11/20/13. So a few months later, and this is an arthrogram. And let's go through the shoulder on the arthrogram.
Okay. Well, now we're disfitted with contrast, and we see this rather linear appearing structure, which seems to be extending from the glenoid to the femur.
Are you talking about this?
Yeah, and then, well, then also kind of between that and the labrum. I mean,
This thing.
we're going to need to follow that guy, yep. Okay. Still coming through, so I think it's, you know.
So let's go back again. So here we have here's what we have here are these two structures, and this is called an anterior labral tear. We have the middle glenohumeral ligament, the base of the labrum, and is this labrum or is this superior insertion of the anterior band of the inferior glenohumeral ligament? Okay, so and then if we go to the here we can't really separate things here very well without fluid. Now we put fluid in the joint space. If we follow it up here, what you have here is a prominent anterior fold. There's the labrum. You have this structure here coming up there. Those two structures there, and then and here is that common origin that we've talked about repeatedly. If we go to the oblique sagittal images, now with contrast in here, we can actually see that we have the subscapularis tendon, and middle glenohumeral ligament. If we go one cut over here, we got subscap tendon, middle glenohumeral ligament, and then what's this structure?
Okay, so yeah, I think this is going to be a superior insertion of that inferior.
So I just want to go back and remind us of what we talked about yesterday. That can be confusing, but it's important to follow these structures up and down to see where they come from. And if you follow that triangular structure on repeated slices, you find that if you go inferiorly, it went to the capsule. It didn't go back to the labrum, and therefore it was not a labral tear.
The superior. The way I understand it, superior inferior glenohumeral ligaments are quite constant. It's pretty rare to have them absent. The middle one, however, is not. The middle glenohumeral ligament is quite frequently not present.
If we go back to the axial images on this case, is the anterior labrum absent anteriorly and superiorly? Like if you keep going higher? Or is that too high? Okay.
And we're getting up, this is, I don't know, we have to look at all the images. We skipped a bunch of steps here. And this is that common area where the anterior labrum, the superior insertion of the interband of the inferior glenohumeral ligament, the middle glenohumeral ligament, and the superior glenohumeral ligament all come together. So I'd have to look at all the individual images to clarify.
That next slide is supposed to say superior attachment of the IGH, right?
Oh, what did I say? Yes. Thank you. Okay. Better? Thank you. Say, Jeff, what do you think of this one?
43-year-old male rule out subscapularis tendon tear, axial PD, so like an image, T2. Looks like so looking at the subscapularis tendon, there's definitely intermediate signal I don't see a tear per se, so I think it's just at this point distal subscapularis tendinosis.
Okay.
You're asking me to evaluate the looking at the I should probably say so looking at the anterior inferior labrum, I see a fluid or some signal passing through the labrum. It looks
okay, you have three structures here. That structure,
yes.
that structure, and that structure. So is this a tear or what's going on here? Next cut, or that's a.
All right. So on this image here, I see the labrum. It appears to be intact, the anterior inferior labrum, and
So let's go back again.
okay. So right. All right. So okay. So on this, all right. So what I'm seeing now is, I believe, in following these images here, the anterior inferior labrum is intact, and what we're seeing is another structure which I believe is high attachment of the anterior of the high attachment of the inferior glenohumeral ligament.
Okay. So if we look at this, we have these structures here, and
yes,
and we see the most anterior structure has kind of a gray signal. Then we have these two structures which are dark. If we follow them down, here we have those three structures. Now notice these two, there is this cleavage plane between them. If we go to the next cut down, those two seem to come together in the labrum, and that other structure is very gray and thickened and continues to go more inferiorly, and then comes down here where it looks like it's going out toward the capsule.
All right, so that intermediate signal
images, and here we have this black structure and this gray structure coming all the way down here.
Yes. So the gray structure, yeah, I was going to say it's the degenerated attachment of the inferior glenohumeral.
So this is a tear of the anterior labrum with an injury to the anterior band of the inferior glenohumeral ligament. And the reason we can say it's a tear of the labrum is because, so the question is this plane between two pieces of labrum, or is this between the base of the labrum, a labrum, the superior insertion of the middle of the inferior glenohumeral ligament and the middle glenohumeral ligament? And the only way to really determine that is to follow it down, and we see that peripheral structure actually is the anterior band of the inferior glenohumeral ligament. Those other two structures fuse down here to the labrum, so we know then that this is a labral tear, and this is an injury to the anterior band of the inferior glenohumeral ligament, and we're not seeing the middle glenohumeral ligament here. Okay, so again, I'm just saying the only way to figure these things out is to follow the structures up and down so you know what structures you're dealing with. Okay, is that clear?
Yes.
Okay, well, why don't we actually stop here, and we'll continue our merry little dance tomorrow. Okay, any questions?
Thank you.
Thanks.
Have a good one, everybody.
Thanks, John.
How are things going?
Great.
Good.
Oh, good.
We'll talk tomorrow.
Okay, thank you.
Have a good one.
Great. Bye.
All right.